Okay. Well, thank you for having me. It's great to be here. Make sure that I can advance the slides correctly here. They'd like me to do a disclosure slide, so here's my conflict of interest disclosure. I don't have a slide, but I have participated with my institution in COVID clinical trials sponsored by Roche, Genentech, AbbVie, Gilead, Regeneron, and the National Institutes of Health. Currently not registered with a political party. I drive a 2012 Corolla. And I'm told I have haters on Facebook. I'm actually delighted to see that the entire room didn't empty out at the hint that we were going to be talking about COVID one more time. So thanks for staying. I'm gonna actually try to tackle a fairly comprehensive topic. Therapeutics in COVID have been such a moving target and in evolution for the last 18 months. I'm not gonna try to be exhaustive here, but we'll try to hit principles that I think will be still applicable next week and next month, and try to touch on what's coming down the pike to some degree. I think for me, in terms of understanding the therapeutics, it's actually most helpful to pin it to the continuum of disease. And so I use this slide to kind of paint a picture of the continuum of COVID-19 pathophysiology, in which early on we have a virologic phase, which is really marked by prolific replication of the virus, invasion into the respiratory epithelium. And then what I call the transitory phase. It's really, for lack of a better term, a middle phase where we still have active viral replication. The virus itself is still playing a role pathophysiologically, but it's also started to trigger this maladaptive inflammatory cascade that causes much of the collateral damage that we see symptomatically. And then finally, a late inflammatory phase where the effects of the virus itself and the replication largely has run its course. And it's the continued pathophysiology in the late inflammatory phase is really driven by maladaptive inflammation, organ injury, and the consequences thereof. Understanding that continuum then helps us to understand where the various therapies fit best, and rationally where they don't fit, and where we've actually seen some harm signal in the case of some of these therapies. I wanted to make it also a point of emphasis that this is still a bike that we're building as we ride. It's still a very, very much a moving target. And with a brand new disease, we continue to be in a constant phase of discovery. And, to be candid, I think that's been really challenging, not just for providers, but very challenging for the public. Because for the first time, really, in at least modern medical history, the media coverage of scientific discovery in the therapeutic domain has been intensive. And we're hearing now about new trials that have not even been peer-reviewed yet, but yet are being covered in the mainstream media. Sometimes to the confusion of our patients and the public. I also wanted to point out that research has played really a very critical dual purpose during the pandemic, where not only has it been the most important means for understanding what does work and what does not, but it's also been the preferred access for unproven therapies. And it remains the most, the preferred access point for some of the unproven therapies. And as evidence has accrued, we've been able to move things over from investigational to emergency use authorized to fully approved yet not fully understood. So I'm going to start and actually just tackle the therapies for each phase. And we'll start with the early virologic phase. And I'll try to answer questions as we go. I think if we wait till the end, that we may regret it. So if you have questions, please feel free to stop me, raise your hand, and we'll pull over. So let's talk about the early virologic phase first. So the virus itself really plays the most active role in the first couple of days prior to symptom onset, and then in the first 7 days after symptom onset. We know that the viral load in the upper respiratory tract and in the lower respiratory tract don't peak at the same time. The viral load in the upper respiratory tract peaks very early on, sometimes within the first 48 hours of symptom onset, whereas the viral load in the lower respiratory tract can peak later in the course. We also know that patients are viremic only very briefly. It's very hard to catch a patient with SARS-CoV-2 viremic in the act. And that's really only been identified episodically in the immunocompromised and in patients who are critically ill in the ICU. We also understand that during that virologic phase, the immune system is working very hard to control a virus that is built to evade the immune system. And what that results in is really a maladaptive immune response that then results in the later collateral damage, the inflammatory process that we see later on. It's worth noting that successful control of the virus of SARS-CoV-2 early on during the virologic phase requires an intact interferon response. It means that the macrophage and the T cell interaction has to be intact and it has to be unsuppressed. And I'll point out why that matters in a little bit. Now, our therapeutic options for the early virologic phase, not surprisingly, are focused on controlling the virus, and logistically are very challenging because identifying patients and identifying them as laboratory-confirmed positive COVID-19 patients very early on remains a significant barrier to early identification and treatment. It's also worth noting that some of the immunosuppressive or anti-inflammatory therapies actually may be harmful during this phase. And that actually has to do with the necessity of an intact interferon response early on. So I'm going to only talk briefly about vitamins. I think it's worth noting that although there's a tremendous amount of interest in vitamins for early COVID-19, there's very little data still. Even now, 20 months in, we have very little in the way of well-done, methodologically quality data. We do know from our experience with other respiratory infections that vitamin C does have some activity early on in upper respiratory infection. There's a really nice Cochrane meta-analysis that does include patients with the endemic coronaviruses that does suggest that there is a symptom shortening effect of vitamin C on the order of about 1 gram a day. But it's interesting, in that meta-analysis, the effect was actually most prominent in patients who were taking the vitamin C chronically, not episodically. So once the symptoms are recognized, it's likely that the cat is out of the bag in terms of the efficacy of vitamin C. We'll talk briefly about vitamin C in the later phase in terms of oxidative stress and vitamin C's role as an immunosuppressive or immunomodulatory compound as well. Vitamin D is very well known to influence immune function. It plays a number of very important roles in immune function, and it's hypothesized that the appropriate immune response to respiratory viruses does require adequate levels of vitamin C. And indeed, we have a number of epidemiologic studies now in COVID that prove that patients who are deficient in vitamin D do tend to have poorer outcomes, even when adjusting for age and comorbidity. These studies, most importantly, do not, however, indicate that supplementing with vitamin D at the time of diagnosis has any impact at all on the course of disease. It's, again, probably one of those cases where the cat's out of the bag. So the bottom line with vitamin D is it's relatively innocuous, but we should be, let me take a step back. I recognize as well that in the primary care world, vitamin D supplementation is also a moving target and somewhat controversial as well. But in COVID-19, I think the most appropriate messaging here is that patients who are adequately repleted with vitamin D tend to have better outcomes. Zinc, finally, is another interesting compound, one for which there is meta-analysis data that if taken prophylactically or at the time of first symptoms. It may reduce the symptomatic duration in upper respiratory infection. There are some concerns with toxicity in terms of copper deficiency with long-term use of zinc. And we don't have robust data in COVID-19 that it really moves the needle in terms of symptom effect early on. Let's talk a little bit about monoclonal antibodies. Monoclonal antibodies were developed very early on, or the development of these products began very early on. Once the spike protein was sequenced and the epitopes on the spike protein that interact with the ACE2 receptor were identified. From there, there was a rapid movement to develop recombinant monoclonal antibodies that would bind avidly to those structures on the spike protein and neutralize the virus and also paint it for removal, opsonization. It was actually remarkably quickly that we saw some of these early monoclonal compounds go from being used for diagnostic purposes and then actually move into phase 1, phase 2, and then phase 3 clinical trials. As you're, I'm sure, aware, there are currently 3 monoclonal antibody compounds or products that have achieved or been approved with an emergency use authorization. They all have tongue twister names: bamlanivimab, etesevimab, which is it's a Regeneron. Excuse me, that's a Lilly product. Casirivimab, imdevimab, which is the Regeneron product, and then sotrovimab, which is a Glaxo product. In this table, I've summarized the efficacy data from the phase 3 trials for each of these products. What you see is that each of the trials for each of the 3 compounds enrolled very similar target populations. These were all patients who had risk factors for progression and poor outcome, namely hospitalization, and the risk factors tended to be advanced age or multiple comorbidities or immunosuppression. There were some variations on a theme, but in general, the target enrollment population for each of the 3 products in phase 3 trials were similar enough that we can say, to some degree, that we're comparing apples to apples. What we see in the phase 3 trials for each of these 3 products is that compared to placebo, each of them have shown fairly remarkable efficacy in preventing the progression of COVID-19 to the point that it requires hospitalization. So the column labeled efficacy refers to the primary endpoint, which for the casirivimab imdevimab trial was originally medically attended visits of any kind, and then they shifted and only looked at hospitalization so that these could be compared with bamlanivimab, etesevimab, which primarily looked at hospitalization, as did sotrovimab. And what you can see is in the all-comers population, each of them had roughly a 70% relative risk reduction for progression and the requirement of hospitalization. Several of the studies did subgroup analyses, which are very helpful for us, where they looked only at patients who are in the highest strata of risk for going on to have hospitalization. And what we see there is that the relative risk is actually, the risk ratio is even more broad, even more favorable, because the usual care group or the placebo arm had higher rates of hospitalization. And what that equates to is the ability to calculate a number needed to treat, which for bamlanivimab and casirivimab in the highest risk strata is approximately 10 patients infused to prevent 1 hospitalization. In the all-comers group, in other words, the column that I have noted as efficacy, the number needed to treat is roughly 20 to prevent 1 hospitalization. That becomes very relevant now in the setting of a very highly regulated, limited resource that's very logistically difficult to deliver, and in a hybrid medical model public health initiative where we have these drugs available and we're trying at the population level to use them to do the most good for the most patients. And what that means is that currently, under the current paradigm, monoclonal antibodies are designed to be given to patients who are at that highest strata of risk to prevent hospitalization. And the reason for that is because of relative scarcity, not because the drugs are in short supply necessarily, but because the logistics of giving an actively infected, contagious patient an infusion that requires them to then compete with access for care for other patients, whether it be in an infusion center, an urgent care setting, or a very busy ED, bumps up against barriers that are logistic constraints rather than drug shortages. We look forward then to a time when those shortages are alleviated. And I think it's worth mentioning that shortages are a two-way street. They are bound not only by the capacity, but also by the number of patients in a community that are positive. And I think that that really highlights one of the main points that I'd like everyone to walk away with, which is that preventive measures and vaccination are primary preventive measures, and they are far more effective and much more efficient at preventing hospitalization, ventilation, and death than any of the therapies that we're going to talk about today. I think it's also worth mentioning that 2 of these products have been studied in phase 3 trials for post-exposure prophylaxis in patients who are at high risk as well. And in both of those studies, the patients were treated within about 4 days of their exposure. The exposure had to meet CDC criteria for a direct contact with a positive COVID patient. And in both of those studies, the relative risk reduction for going on to have laboratory confirmed COVID was about 80%. Because you're one step upstream with post-exposure prophylaxis, in order to prevent one hospitalization, you have to do post-exposure prophylaxis in roughly 100 patients to prevent one hospitalization. And for that reason, in this medical model public health initiative, it's not an efficient use of a limited resource. It's really focused on those patients who are truly at the highest risk, the immunocompromised, especially those with humoral deficiencies. Before I move on, are there any questions about monoclonal antibodies that we didn't tackle? Right. That's a great question. So let's, a little bit later in the phases of illness, I'll tackle it, but let's tackle it right now. There are ongoing clinical trials looking at the effect of monoclonal antibodies in those who are already in the later stages of disease and hospitalized. And interestingly, there's actually a very clear harm signal when given to patients who are late enough in their course that they're requiring high flow or mechanical ventilation. It's not well worked out why there's a harm signal, but it does appear that there's probably some component of antibody-dependent enhancement. And so for that reason, we were able to get compassionate use approval for monoclonals in inpatients for a time. And when those data started to emerge from the inpatient trials, the FDA said, actually, no, not even compassionate use, because we actually can't say that these products don't cause harm in the later stages. We do have data from the Recovery UK trial where they used it in earlier hospitalized patients who are less hypoxemic. And in that group, there was a mortality advantage even with usual care, including other anti-inflammatories, but only in the patients who were still seronegative. In other words, patients who had, at that point in their disease, already generated an antibody response by themselves, derived no benefit at all from the monoclonal antibodies in-house. Whereas patients who, for reasons probably intrinsic to their immune system, hadn't started to generate an antibody response, they did benefit. And that actually has opened a Pandora's box question, which is, now in the era of vaccination, are these monoclonal antibodies in inpatients only effective in the unvaccinated? And that question has yet to be answered. Terrific question. Thank you. Any other monoclonal queries? Okay. Let's talk a little bit about some real-world effectiveness. These are some observations from Utah patients, and so I wanted to share some of our observations. We have been using monoclonal antibodies in Utah now since December of 2020. In the state, we've treated about 5,000 patients. And so we have a fairly good understanding of how these drugs work, their tolerability, and this subsequent course after giving monoclonal antibodies. Now, of note, in the state of Utah, we have been focusing on the highest of the high-risk strata with these drugs. And so our number needed to treat, having looked at this with a propensity-adjusted model, in the early phases of the pandemic was around just under 8. It was actually terrific. As the pandemic has progressed and more of our population is vaccinated, those individuals we know have lower pre-treatment likelihood of requiring hospitalization, and so that's actually broadened out our number needed to treat. So it looks like the effectiveness of monoclonals has started to shift in the wrong direction, but it's actually just a product of a greater rate of vaccination uptake. We estimate right now that the number needed to treat to prevent one hospitalization is roughly 12 to 16, depending on vaccination status. And we do know with fairly good accuracy which of the patients who are vaccinated still have high risk for going on to hospitalization and other poor outcomes, and are able to kind of risk stratify that way. We can also say now with confidence that these are very well tolerated. The absolute or overall infusion reaction rate is just over 1%, and very few of those have been severe. We've used about 3,000 of these since December and haven't had any cases of anaphylaxis, importantly. We've had some chest pain, some syncope, and a number of mild infusion reactions, but overall very well tolerated. On the right, you see a graph. This is age and risk-adjusted probability in any given patient over time that they would go on to require hospitalization pre and post the advent of monoclonal antibody therapy. And what you can see is that there's been a clear decrease in the probability that a patient requires hospitalization if monoclonal antibody therapy is available and if they're eligible. Let's shift gears and talk about antivirals for just a moment. Remdesivir is very well known at this point. It's a nucleotide analog that was originally developed for other RNA viruses and was co-opted very quickly early in the pandemic and tested against SARS-CoV-2. It works by blocking the replication of the virus. And so as you'd expect, it should work more effectively in the very early phases when the virus replication is at its peak and where the majority of the pathophysiology is from viral replication rather than inflammation. Despite that, remdesivir was actually initially studied in the hospitalized population. And we'll talk about some of the outcomes in just a minute when we get to those later phases. Most importantly, though, we just last week had results announced from another phase 3 clinical trial of remdesivir, this time targeting early symptomatic ambulatory patients who are within the first 7 days of symptom onset and who had risk factors for hospitalization. And interestingly, and perhaps not surprisingly, the effect of remdesivir in that population was dramatically different than what the nominal effect we see in hospitalized patients. When used early with only 3 days of therapy, patients who received remdesivir had a significantly lower rate of hospitalization than the placebo group, roughly 5% in the placebo group, 0.7% in the remdesivir. So the hazard ratio after stratifying by age was 0.13. This holds a lot of promise for early therapy. And so one question that comes up immediately is, well, why haven't we shifted gears? We know that monoclonals are logistically difficult. Remdesivir is FDA approved. The current barrier is that until the FDA weighs in on this new indication, no payers are covering remdesivir, and it's still prohibitively expensive. So we're anticipating that the FDA and payers will move quickly so that we have another tool in the toolbox. Just in case you were wondering, by comparison, the number needed to treat to prevent one hospitalization in the all-comers population in this study was about 20. So on par, very similar to the number needed to treat that we saw with the all-comers population from the monoclonal studies. And we'd expect that that would be even lower in the highest risk populations. Perhaps most exciting of all of these is the recent announcement of efficacy from a phase 3 trial of an oral nucleotide analog, molnupiravir. This is a product that had actually been developed for many years after the SARS epidemic, or the SARS outbreak, I guess. This compound was developed with coronaviruses in mind, and when the SARS-CoV-2 outbreak began, the company Ridgeback Therapeutics in one of the, I think it was North Carolina, quickly pivoted and found that there was promise here and has moved it through clinical trials. We anticipate that we'll have FDA emergency use authorization for this product probably by mid-December, which is a very welcome addition to our toolbox. The reason this is so welcome is that the logistical barriers and the manufacturing issues that are constraints to monoclonal antibodies and remdesivir don't apply to an oral agent. In the phase 3 clinical trial, which was actually stopped early after the Data and Safety Monitoring Board recognized that there was clear efficacy, about 760 high-risk, again, early ambulatory patients were randomized either to a 5-day course of molnupiravir, which is an 800 milligram tablet taken twice a day, or placebo. And the primary endpoint in this trial was 28-day hospitalization or mortality. And what you can see here is there was a roughly 50% reduction in the primary endpoint in patients who received molnupiravir. That equates to a number needed to treat of approximately 15. We haven't seen the peer-reviewed manuscript yet and don't have safety data, so we don't know if this is going to be limited somewhat like Tamiflu. You know, we all know that there are some very important issues with nausea and intolerance with Tamiflu. So we do have some unknowns with the product, but we are very anxious to see how this plays out. Just to look down the pike a little bit, we know that Merck has already pre-committed to producing about 10 million courses by January. And 2 million of those courses have been pre-purchased by the Department of Health and Human Services for use in the United States. And then the other courses are going to be distributed, at least initially, outside of the US. That means that when focused on the patient population that was studied in the trial, which is very similar to the patient population that's being targeted with monoclonal antibodies, we should have about 2 months of supply. That means that we're again going to be dealing with a limited resource, and it's not going to be a situation where this is available for all of our patients immediately. But we hope that as this manufacturing ramps up quickly, that we'll be able to have more rapid access for patients earlier in their course. So I think without being accused of hyperbole, we don't talk about game changers appropriately in COVID very often, but this is one drug that does have the potential to be a game changer. Let's talk just a moment about some repurposed drugs. There was a lot of interest early on in hydroxychloroquine. It does have some in vitro basis for efficacy in terms of changing the pH of the lysozyme and making it more difficult for the virus to enter the cell. This drug also has some obvious anti-inflammatory properties as well, acts on the T and B cells. It also blunts interferon. And remember, in the very early phases of disease, interferon is helpful. And so it's possible that there may be some pros and cons. And what we saw over the course of several months was a lot of interest. And then one by one, clinical trials started to report data. We had one running here in Utah as well. These have now all been pooled. The data is still under review, but I'll just share with you over 1,200 patients in the pooled individual patient meta-analysis, and there was no benefit at all in terms of prevention of meaningful clinical outcomes. On the flip side, fluvoxamine, which is a little used SSRI, it's most helpful in obsessive compulsive disorder, has been identified as having some in vitro antiviral properties, but probably more likely anti-inflammatory properties. And so because of that, it's been now entered into several pragmatic clinical trials, one of which, the Together trial, recently reported data on fluvoxamine in a population fairly sizable, more than 3,000 patients enrolled. This was in Brazil. They were randomized to fluvoxamine, placebo, or other therapies. These were, again, early symptomatic ambulatory patients, and the endpoint here was ED visit or hospitalization. And interestingly, here we did see a difference in the primary endpoint of about 4 percentage points, or about a relative risk reduction of about 30%. Those results were statistically significant. That's interesting. It's promising. There's a second corollary study, the ACTIV-6 study, that is currently enrolling for any patient nationwide who's interested in participating. And that is an option for any patients who are interested, regardless of where they are. So for outpatients, if you have patients who are interested in participating in a clinical trial, ACTIV-6, Google ACTIV-6, and there's a patient portal. We're very interested to see if that study corroborates the observation of the Together trial. We have seen now over the course of the pandemic the need for good data corroboration, because observations in one population have very clearly not borne out in other populations, but it's very intriguing. Finally, no COVID talk would be complete without some ivermectin. I wanted to just talk a little bit mechanistically about what ivermectin is, since I think I was one of the few providers in the state pre-COVID who ever used it. And ivermectin is an interesting compound. It does have some putative anti-inflammatory properties. In vitro, it was observed to also have some antiviral properties, but it's worth noting that that was in concentrations more than 50 times greater than what we use clinically for onchocerciasis or strongyloidiasis. Because of that observation, there was a lot of interest, and now dozens of clinical trials, or maybe more appropriately, clinical studies have focused on ivermectin. Unfortunately, the vast majority of the clinical studies have been of very poor methodologic quality. And that's unfortunate, because the data observed is in almost all of these studies is very prone to indication bias. Patients who are less prone to severe outcomes tended to be the ones treated with ivermectin. There's now been a couple of well-done meta-analyses that focused only on the randomized controlled trials that were more methodologically robust. And in both of these meta-analyses, the conclusion was that it's impossible with the current data to discriminate between harm and benefit, meaning that the confidence interval straddles harm and benefit almost equally. In other words, we simply can't tell from the available data whether there is harm versus benefit. And for that reason, nearly all of the regulatory and major scientific organizations have currently committed that ivermectin should not be used outside of a clinical trial. Now, both of those meta-analyses were actually conducted prior to the advent of the Together trial, which is a platform study and has multiple therapies. The Together trial results were just released a couple of weeks ago. And importantly, this was a very well-conducted, randomized controlled trial. I showed you the results from the fluvoxamine arm. In the ivermectin arm for the Together trial, more than 1,300 ambulatory patients were randomized to a 3-day course of relatively high-dose ivermectin versus placebo. And here, the results were not statistically significant in favor of prevention of hospitalization. You can see that the confidence interval straddles 1. So that is the first very good quality randomized controlled trial that informs the efficacy of ivermectin. And I think from that trial, we can interpolate that ivermectin is not likely an effective antiviral, and compared to some of these more promising therapies, has very little potential for offsetting or preventing the progression of disease. We'll talk about briefly the hospitalized setting as well. There, the data is even poorer. But in the clinical trials in the hospital setting where ivermectin has been used in addition to what we now recognize as standard of care, including anti-inflammatories, no adjunct or no additional benefit was noted in the hospital setting. No, and I think it's good to be transparent about that. I think we've heard, if you take ivermectin, that you can have XYZ. Ivermectin is actually very well tolerated, and I don't think we do ourselves any favors in terms of transparency and confidence by pretending that at clinical doses there's a significant harm signal. There is not. At veterinary doses, absolutely. There are some significant issues with encephalopathy. But at clinical doses, the issue here is not the risk of harm. The issue here is the likelihood of benefit. Even if the confidence interval in the Together trial had been, if they'd powered it to 10,000 or 12,000 patients and had seen the same effect size, the number needed to treat would be roughly 1 in 200. So. I'm not aware of any good quality data. Its hypothetical antiviral properties are for RNA viruses, of which West Nile is a flavivirus. So it's possible that there's some effect. I think for patients living in North Davis County and South Weber, especially on the west side, a much better advice there would be to wear a good 20% DEET or higher. Yeah, not even close. By relatively high, it was roughly 2 times the weight-based dosing that we would use for strongyloidiasis. And in strongyloides, of course, we use it 2 doses, 2 weeks apart. Here it was every day for 3 days. So quite a bit higher doses than we would use for roundworm or hookworm, but roughly 25 to 50 times lower than the in vitro concentrations. All right, I'm going to move on. As much as I love ivermectin, we're going to move on. Let's talk about we want to make sure there we go. Let's talk about the middle phase, because the middle phase, I think, is really the most frustrating to us as clinicians, because this phase is where we have a lot of patients in the evidence donut hole, the black hole of what works, what doesn't, what may be harmful, what may not. We know that in this middle transitory phase, patients who are somewhere between day 5 and day 14 of symptoms still may have some viral replication, but are also now starting to exhibit some lower tract disease. They oftentimes are now starting to have some evidence of the inflammatory cascade. And so I think a lot of our experience with patients as we see them is, would these patients benefit still from antivirals, or are there anti-inflammatories that would be safe, and how do we figure out which is which? And this is really an area where we desperately need additional research. We have multiple ongoing clinical trials that will inform this. Like I said, in this phase, there's a waning of the viral replication, and so we do expect that antivirals probably have also a waning effect. And also the anti-inflammatory therapies may be helpful, but as I'll point out, there's actually some evidence that if not used in the right patient, they may be harmful as well. We do have some data from the Act 1 study with respect to this donut hole population. patients in the Act 1 remdesivir trial who were hospitalized but not hypoxemic. And again, that tells you when this trial was done. We don't have any non-hypoxemic hospitalized patients who aren't pregnant for fetal monitoring or immunocompromised with GI disease. But in that phase of the pandemic, there were still hospitalized patients enough to study. And in that setting, there was a benefit. The rate ratio for recovery was favorable by on the order of about 30% benefit for patients receiving remdesivir and recovering more quickly. So there probably is some benefit in those patients that are in that middle transitory phase to antiviral therapy, but it wanes after you get to about day 7. And we know that from the monoclonal antibody trial as well. Each of those trials enrolled patients up to day 7 of symptoms. And even though the FDA authorized the use of monoclonal antibodies through day 10, we actually have 0 data for how well they work after about day 7. And we do know that the viral levels start to decrease significantly. So there is some unknown there. I did mention the Recovery UK data about the use of monoclonal antibodies in those patients who are hospitalized with relatively mild disease for a hospitalized patient. And in that setting, it does appear very important that patients be seronegative to derive any benefit from monoclonal antibodies. I'll only spend just a moment here in terms of talking about the hyperinflammatory complications of COVID-19. We found it very unsatisfying to not have a platform or an ability to quantitate what the hyperinflammatory process was. So we actually early on studied a cohort of patients who were admitted to the hospital with COVID-19 and tracked their outcomes with respect to their hyperinflammatory laboratory values. And then we studied other hyperinflammatory conditions, other cytokine storm syndromes like we see after CAR T therapy, or what we see after hematologic malignancy, for example. And what we found was that the framework used for the diagnosis of HLH fit the COVID hyperinflammatory syndrome quite well, with the adaptation to some labs that are unique to COVID-19. For example, the neutrophil to lymphocyte ratio is very important prognostically in COVID-19. The wider that goes, the lower the lymphocytes, the higher the absolute neutrophils, the poorer the prognosis. We also know that D-dimer is important, as is LDH. And what we found was that if we looked at 6 categories, fever, markers of macrophage activation, hematologic dysfunction, coagulopathy, hepatic injury, and cytokinemia, we were able to count the number of factors accrued, the number of categories met every day of the hospitalization, and then look and see how the outcomes played out. And what became very clear were that patients who have at least 2 or more of these COVID hyperinflammatory symptoms have a very clear difference in prognosis. You can see that those patients who went on to mechanical ventilation were much more likely to have a CHIS score of 2 or greater. What that allows us to do is actually to triage patients, even in the outpatient setting, with some relatively simple and accessible lab tests to see how much they have now developed the hyperinflammatory syndrome. And we're actually using that now in our emergency departments to triage patients for appropriateness for admission versus home monitoring. Oral corticosteroids are fascinating in this middle group. We don't know yet whether they help or harm, and we're anxious for data there. Remember that that interferon response is critical, and we know that corticosteroids are very potent at impairing the interferon response. We have data in COVID that if used too early, it actually enhances viral replication. So we have seen clinically cases where patients were given steroids early in their course and had a fairly robust worsening within several days. On the flip side, patients in this donut hole that are later than a week into symptoms may very well benefit from oral corticosteroids. But I think anti-inflammatories should be treating patients with hyperinflammation. And so we really need research that helps tie those two together, a way of quantitating, measuring inflammation, and identifying patients in which corticosteroids are likely to help rather than harm. Now, importantly, and I'm going to have to pick up the pace here, We do have 2 very well done UK studies of inhaled corticosteroids that recently resulted out. And I think these are very encouraging. It gives us a nice tool in our toolbox for these donut hole patients. In both of these studies, high-dose budesonide was used. These were used at doses that we don't have here in the US, but we do know there's a therapeutic interchange that is fairly similar for what we consider our high upper limit dosing of fluticasone and mometasone. And what these 2 studies showed was when treating patients in that early to medium window after symptom onset, somewhere in the first 14 days, when given a course of inhaled budesonide, there was decrease in the rate of progression to hospitalization and also an almost 3-day difference in the time to symptomatic recovery. And I think that this is really maybe getting underplayed a little bit amidst all of the other chaos of COVID, because these are therapies that are widely available. Our pulmonary colleagues do emphasize that if these are going to be prescribed for patients who don't usually use inhaled corticosteroids, that good education is very important here, and that HFAs may be better than MDIs just in terms of the ability for a patient who's never used one to use it successfully. Let's talk about the late inflammatory phase. So in this phase, generally, we're talking about patients who are at day 8 or greater of their course. In this portion of the disease, viral replication has really decreased quite a bit, except in the very critically ill, where we actually have patients who are viremic or have significantly or persistent high levels of lower respiratory tract viral replication, and the immunocompromised. In this late phase, there is considerable hyperinflammatory markers by any metric. And we also generally are seeing lower tract disease by this point with hypoxemia. And in this phase, as you'd expect, we should see a waning benefit of antivirals. And in fact, that is what we see in the clinical trials. And the anti-inflammatory therapies start to play a much more important role here. This is the data from the Act 1 remdesivir trial. On the right, you see the 5 boxes representing patients who were not hypoxemic at randomization, patients on low-level oxygen, patients on high flow, and patients who were requiring mechanical ventilation or ECMO. And in this population, what you see is that the greatest benefit for remdesivir was actually in the patients who were on low, meaning 4 liters or less supplemental oxygen. Now, it's very important to recognize that that study was done before the Recovery UK dexamethasone results, and so very few of these patients were receiving corticosteroids. So I think what we can say is that in the pre-steroid era, remdesivir does have a mortality benefit in patients who are mild for hospitalized ilk. And now, with the corticosteroids having such a prominent mortality benefit, it probably washes out all but just a little bit of the benefit of remdesivir. And that's what we saw in the Solidarity trial that received a lot of press that led to the WHO suggesting that remdesivir was not effective. From a scientific standpoint, we actually can't say that remdesivir doesn't add adjunct or additional incremental benefit on top of anti-inflammatories, or in which patients. Those studies still need to be done, and in fact, there is an NIH trial that's looking at remdesivir plus anti-inflammatories versus anti-inflammatories alone, and I think that's going to be critical for us understanding really how much benefit hospitalized patients get from remdesivir. Monoclonal antibodies, I'm glad we already tackled this. They likely have some role in the early hospitalized seronegative patients where they have probably an incremental mortality advantage. But we are limited right now that our antibody tests are not standardized, and so it's going to be very difficult for the FDA to weigh in, and it's actually been over a month and a half since this resulted out, and they still haven't weighed in, likely because of the difficulty comparing apples to apples with the antibody tests that we would need to be able to say whether a patient's truly seronegative or not. Currently, these are not approved for inpatient use. Now, it's no secret, oral corticosteroids have really been life-saving in patients who are severe in the late inflammatory phase with COVID-19. It's really also important to recognize that in the Recovery UK data, patients who were not hypoxemic at the time of enrollment actually had worse outcomes when treated with corticosteroids. So their rate ratio was on the wrong side of 1. It was 1.19. We don't have hyperinflammatory labs from the Recovery UK trial, so we can't say whether those patients also had very low levels of inflammation. But fortunately, two now later studies, one very large multi-center study from France and another one from New York, have confirmed our suspicion that patients who don't have hypoxemia at rest or evidence of hyperinflammation don't benefit from corticosteroids and may actually have a harm signal. We do, one still lingering question with corticosteroids is what dose should we use? We've been using 6 milligrams of dexamethasone, which is equivalent to about 35 milligrams of, or 34 of methylpred or 40 of prednisone, roughly. There are a number of trials that have used larger doses, mostly methylprednisolone, and a recent randomized controlled trial comparing 12 milligrams of dexamethasone with 6 milligrams of dexamethasone suggested that there may be some benefit to higher doses. But it looks like that benefit is really, if you look at the forest plot, it's really limited to patients who are in the highest of the hyperinflammatory phase, which tend to be the patients in the ICU. And we also don't know, importantly, whether high-dose corticosteroids are equivalent to low-dose plus adjunct immunosuppressive therapies. We suspect that that's probably the case. We have a lot of data now on low-dose corticosteroids plus tocilizumab or plus tofacitinib or baricitinib. I think these data suggest that it may be that higher doses of corticosteroids are similarly effective as low-dose plus adjunct immunosuppressives. And I'll finish up with a couple of quick slides about these adjunct immunosuppressive therapies. Tocilizumab has now been so robustly studied, and in the observational studies, we saw fairly dramatic reductions in mortality in patients who had very high CHIS scores. So we actually looked at all these trials and applied the CHIS criteria and can say that patients who have significant hyperinflammation do benefit from steroid plus tocilizumab. The trials also suggest that patients who are not treated with steroids and are treated with tocilizumab have very little benefit. And that's one of the reasons we saw significant differences in the randomized controlled trial data. I think that now, after 12 randomized controlled trials, we finally have a decent understanding that tocilizumab, when given to the right patients in the window where there's still a potential to avert poor outcomes, like patients who are on high-flow nasal cannula but not yet intubated, who have significant hyperinflammation, do benefit both in terms of averting the need for ventilation, decreasing ventilatory days, and decreasing mortality on the order of about 20%. Similarly, the JAK inhibitors, both baricitinib and tofacitinib, I think I just bounced right past it, but both of these are also effective when given with corticosteroids on the same order as we saw with tocilizumab. So I'll just finish up takeaway points here. Again, preventive therapy is still far and away the most efficient and the most effective way of preventing these poor outcomes. And antiviral therapy is really most effective when used early on in the virologic phase, and we look forward to antiviral therapies that can be given orally, that are well tolerated, that can be given very early on in the antiviral phase without the logistic barriers. We do know that systemic corticosteroids may be harmful in patients in that early viral phase. And so I think it's important to do our best with outpatients to try to figure out where in their phase they are. But we also recognize that patients in the donut hole phase may benefit from inhaled corticosteroids. And I think that's an untapped potential in our toolbox. And then finally, for those who are down on remdesivir, I think the jury's still out on how much remdesivir benefits patients in the late stages of hospitalization, but the earlier on in the course, the more benefit. And then finally, patients with severe hyperinflammatory syndrome definitely benefit in terms of mortality from the combination of corticosteroids and either immunosuppressive therapies or potentially simply high-dose steroids. And we'll learn more, I'm sure, as these trials continue. The Recovery UK trial is studying 20 milligrams of dexamethasone versus 6. So we will know before too long. It's been a pleasure to be here with you all, and if you have questions, my email is on the last slide. Thank you.